They ride tricycles in the hallway, not in the park. They know the names of their chemo, not their schoolmates. It's their laughter which touches one's heart, and it's their strength which makes an adult cry. That's what's true of children growing up with cancer. Welcome, ladies and gentlemen, to the program Dr. Tapaswini's Corner. That's me, and I work as a head and neck cancer surgeon at the Fortis Hospital. Nothing is more painful than watching one's child struggle through a cancer treatment just to have a chance at life. Unraveling the facts about childhood cancer, we have our expert today, Dr. Gauri Kapoor. You are the medical director of Rajiv Gandhi Cancer Institute and Research Center, Niti Park, Delhi, and also the director and head of the pediatric hematology and oncology. Trained at the Tata Memorial Hospital, Mumbai, and the St. Jude's Children's Research Center, Memphis, USA, you have more than 30 years of clinical experience dealing with leukemias in molecular oncology and stem cell transplant. Welcome, Dr. Gauri, to the show.
Hello, Dr. Tapaswini. It's a real pleasure to be here on your chat show, and I'm sure we'll have some interesting discussion which will be useful to our viewers as well as our listeners.
Thank you so much for spending some valuable time of yours today for the program. So broadly, when we say childhood cancers, what is the age group that we are referring to?
So this is a really interesting question because different people across the world have different cutoffs. But generally, it is believed that both childhood and adolescent cancers should be treated on pediatric protocols. Right. The American Association of Pediatrics, they take it up to 21 years, while the Indian Academy of Pediatrics for the last 20 years have considered 18 years as the cutoff. It has also been seen that adolescents treated on pediatric protocols for cancer do exceedingly well, and they do better than when treated on adult protocols. This, in fact, is published in the Journal of Clinical Oncology.
Okay. How common are these childhood cancers?
As you well know, cancer is actually or essentially a disease of adults.
Right.
Pediatric cancers are believed to be rare conditions.
Mm-hmm.
Having said that, globally, about 3 to 5% of all the cancers are pediatric cancers. Mm-hmm. If you look at the incidence, it's about 150 per million children. Okay. So it's a rare disease, but it has excellent outcomes and it's worth focusing on their treatments.
So what are the various childhood cancers which we get to see in our clinical practice?
Childhood cancers are quite different from the adult cancers. The most common cancers in children are the leukemias and lymphomas, which have excellent outcomes. Mm-hmm. The leukemias are ALL and AML, and in children, 75% of the leukemias are constituted by acute lymphoblastic leukemia, which have cure rates like 70 to 90% long-term.
Well, that's excellent. Yeah.
Right. The AMLs are less common. They are more common in adults. The biology of the leukemia also is supposed to be such in children that it responds very well to treatment.
Childhood cancers, yes, vis-a-vis adult cancers, are they really biologically very different?
They are totally different. The childhood cancers arise from immature or blast cells. So other than the leukemias, we have the lymphomas, and then we have the brain tumors and solid tumors, like the neuroblastoma from adrenal, the nephroblastoma from the kidneys, the osteosarcoma and Ewing sarcoma from bones, hepatoblastoma from the liver, retinoblastoma from the eye, and so on. While in the adults, we have what we call epithelial cancers from mature tissues, like cervical cancer, lung cancer, prostate cancer, breast cancer. We don't get these cancers in children. So the disease is different, and so the treatment is very different.
Okay.
They are fast growing. They require immediate attention. The children tolerate chemotherapy also very well because they have healthy organs.
Right.
So we are able to deliver intensive treatment, which their disease deserves, and therefore the outcome is excellent.
That's a big respite, to all the parents and the caregivers of these children. That gives a lot of optimistic outlook to the treatment also. Yeah, as the cancers, as we say, the symptoms are so very innocuous that we tend to confuse them with other benign diseases. What are those warning signs that we all should be aware of?
So you're absolutely right. There is no unique symptom for cancer. Cancer is
Hmm.
a group of different diseases. Each one has different symptoms, but there is no unique symptom which identifies a disease to be cancer. So it can mimic common childhood illnesses. So, when children are growing up, they have lumps, bumps, they fall here, they have growth spurts, they have mood swings. And with all of this, it often becomes difficult to dwell on a particular symptom and think that it is serious. But you
Right.
also know that we can have excellent survival with childhood cancers only if we diagnose it early and on time and we treat it properly. Therefore, as you rightly said, for the lay public as well as for the practitioner, it is very important that they identify or have a high risk of suspicion and diagnose the condition on time rather than delay the diagnosis when the disease could be pretty advanced and then the treatment complications and outcomes would not be so favorable. So coming back to what are these common symptoms? So P is one of the words that we think persistent symptoms,
Okay.
progressive symptoms.
All
And
right.
what could these progressive or persistent symptoms be? It could be a prolonged fever, which
Mhm.
persists for 2 to 3 weeks. And despite treatments and investigations, there is no known cause. So it's called fever of unknown origin, which persists. It may be associated with other symptoms, not just fever alone, but it may be associated with fatigue. It may be with anemia or pallor. That means the person is looking very pale and weak. It may be associated with neck nodes, with easy bruising or bleeding, with weight loss. So, a constellation of these symptoms would make one suspect that there is some problem with the blood.
Okay.
Because, as you know, blood has three components: the red, white, and platelets, the red
Right.
cells, the white cells, and the platelets. And these symptoms actually stem from the disorder in one of these components.
Okay.
So, in that situation, what we say, if a fever is not responding, it's a good idea to do a complete blood count. It is a simple test. The other symptoms could be neck nodes or lumps and bumps anywhere in the body, which is
Mhm.
unexplained. It could be in the stomach, it could be in the pelvis, in the testes, arms, legs, head, neck, anywhere on the body, which is increasing in size, which has no
Right.
known cause. Often one gets an injury and that directs one's attention to that swelling, but it is
Mhm.
probably not the cause of the swelling.
Okay.
Initially, these lumps and bumps are often painless. They're often
Right.
painless. But later on, when they impinge nearby structures or nerves, they can become painful.
Okay.
So, unexplained lumps and bumps.
Mhm.
Then we can also have white reflex in the eye. Inside the pupils are
Okay.
usually black. It shows like a white
Ah.
reflex, also like looks like a cataract. In young children, it could be a retinoblastoma.
Okay.
Other than that, any change in vision,
Mhm.
any squint developed, any
Okay.
new neurological symptom,
Right.
like a delay in developmental milestone or a regression of milestone or a weakness of an arm and leg or a severe headache, which is persisting and which is often associated with vomiting. But if there is a combination of these, if these
Mhm.
symptoms are persisting over 2, 4, 6 weeks and they are not resolving despite medical attention, then it is time for us to think, can this be cancer? And then what kind of cancer could this be? And what investigation should I therefore advise the family?
Having cancers at such a young age, what are the probable causative factors?
Right. So there's a tremendous, as you know, tremendous amount of research, molecular oncology research that is happening in cancer and also in pediatric cancer. We know cancer is a complex disease. We know that within the cancer cells, there's a lot of DNA change, genetic abnormalities.
Mhm.
But it does not mean that cancers in children is inherited. More than 90% of cancers in children do not have a known cause, despite all this tremendous amount of research that is happening.
Mm-hmm.
And I will suggest that we can even say that it is usually not inherited, it is not hereditary, it doesn't run in family. Mostly it is what we call a genetic accident. So we say it is by chance in more than 90% of the cases. In adults, we know there are environmental factors, like smoking predisposes to lung cancer, tobacco chewing predisposes to oral cancer. We also know chronic alcohol consumption can cause esophageal cancer. So such environmental factors are not evident in pediatric cancers. There is no obvious known cause in more than 90% of the cases. It does not run in families usually.
But is there any role of, the immune system being weak in these children, or any role of radiation exposure, chemotherapy-induced second primaries, or radiation-induced second tumors, or advanced parental age? Does it influence that the child may have, some cancer later?
You're absolutely right. These can cause cancers, very high exposure to radiation, certain drugs like alkylating agents. So these could be, we can say, secondary cancers. So you are using radiation or chemotherapy to treat one cancer, and certain subset of children might develop a second cancer due to these exposures. But by and large, so there are even, by and large, like I said, 90 to 95%, you won't be able to find a cause. But in the rest, few, there may be radiation exposure or drug exposure, or even, in fact, very few families in the world called familial cancer syndrome or Lee-Fromeni syndrome. They are predisposed to cancer, and immune deficiency syndromes, the primary immune deficiency syndromes, ataxia telangiectasia, babies with Downs. Right. These have a higher predisposition, but the total numbers would be very few. So there are rare syndromes. In those syndromes, there is actually a guideline for screening these children. But by and large, 90% would not have any identifiable etiology.
But somewhere there is a role of genetic studies when we are looking at childhood cancers. There is some role of genetic studies in them. Probably would help select a certain patient group who may be at a high risk.
Once the cancer is diagnosed, in that situation, there are certain constellation of features which would suggest that we recommend genetic studies for these children. Like somebody has a bilateral retinoblastoma in a very young age. We would clearly say, please get your other child screened. Then if there is a family history of breast cancer in young women in the family, then we would advise for the P53 genetic test to be done. So yes, there are certain identifiable genetic abnormalities which have a predisposition for cancer. And if the child fits into that clinical constellation, we would advise genetic counseling in those.
Right. So if you look at the investigations, what are the battery of investigations that you run on these little children to diagnose them?
So there are two broad headings under which we would investigate the child. Number one would be to confirm the diagnosis, and the two would be to stage the disease.
Right.
So what about the diagnostic tests? Diagnostic tests are routine tests, like a suspected leukemia would be a complete blood count. And if in the blood count, we see that one or two cell lines are abnormal, by abnormal, I mean it could be a low hemoglobin, a low platelet, a low white count, or a very high white count, I would advise a peripheral smear examination and a bone marrow aspiration test. So for leukemia, that would be a standard initial battery. For lumps and bumps, I would do an imaging. The initial imaging, if it's in the abdomen or pelvis, would maybe just be an ultrasound, like a screening. And if there is a lump or there's a mass, then I would accordingly go further. If it's an extremity mass, like on the leg or on the arm, then I would just get a plain X-ray initially to see what is there. And subsequently, of course, like a CT or an MRI. Thereafter, the lump and bump would require a biopsy. And the biopsy and its histopathology report would then tell me, is this cancer or is it a benign disease? However, you're absolutely right. There are now a lot of advanced molecular tests are done which can correctly identify the disease and also tell us if there is a druggable target. Now we have, as you know, you have heard magic bullet for cancer. So there are some cancers which have a certain mutation which can be targeted with a drug.
Okay.
So that sort of improves the outcome and reduces the side effects. So we also do those molecular tests for certain cancers. It helps us to also do what is called risk and response stratification to look for minimal residual disease. These are all the, the new things that are happening. And we have access to this in India routinely.
So if we look at leukemias, how are they treated? I mean, if I understand, it's primarily treatment which is done is chemotherapy. And how effective is the treatment? How long is the treatment?
So let's talk about the common leukemia in children, the acute lymphoblastic leukemia, which we commonly call ALL. Right? Treatment is mainly chemotherapy based. Treatment is prolonged. It is about 2.5 years of treatment. The initial 6 to 8 months treatment is quite intensive. And during that period, we advise a lot of precautions because these drugs cause immunosuppression. So we don't want the children to be catching infections during the treatment period. So things like personal hygiene, food hygiene, then treatment discipline, strict compliance to treatment. Because as you know, cancer cells are rapidly growing. Because they are rapidly growing, they are prone to mutations. If they don't get their drugs on time, mutation can be one that causing drug resistance and therefore more chance of relapse. So we have to be absolutely disciplined in our treatment. And the outcome for ALL, as I've said, 70 to 90% long-term cure rate. So it's worthwhile putting that much energy and effort into taking the treatment properly with all the precautions.
Right. It's a long drawn treatment as we understand. I mean, 2.5 years. What about the cost issues involved in this entire treatment protocol?
So yes, it is a complex treatment and it is expensive. And I will say that the cost of treatment includes not only just the chemotherapy cost, but also the cost for supportive care, management of infections, requirement of blood products, red cell transfusions, platelet transfusion. And then there are other components of treatment which require multidisciplinary care. For example, the nutritionist, the child psychologist, because the treatment is 2.5 years, you have to ensure these children with their studies, they don't get emotionally depressed. So we have counselors involved very closely with the treatment. We have the dietitian very closely involved. We want them to maintain their nutrition because as you know, these drugs do cause mucositis. They do cause lack of appetite. We have to be always raising their weights and ensuring that their diet is well maintained.
So when we look at the outcomes, I mean, you told us it's got an excellent outcome. So if we compare a developed and a developing country, developing nations, are we at par with the developed countries? Are our drugs, the treatment protocols that we follow is something which the West also follows?
So the drugs are more or less, so the first line treatment for ALL, which cures 70 to 80% children, those drugs are as well available in India as they are any world for the first line. The difference is mainly in the infrastructure. By infrastructure, I mean also the infections and the nutritional status of our children. So this is important. They have fewer infections. The developed countries, the children by and large will be healthier and they would be having less infections. Some of our children come with very advanced disease. So these 2 or 3 factors would definitely affect the outcome. Then the second thing which would be different is the relapse patients or the very high risk patients. Those would be having better options for treatment in the developed world. But for the first line, we have all the drugs. We have all the drugs, we have all the facilities. The treatment here would be as good as anywhere else.
Oh, that's a good news. So people don't have to run to the US or to the West to have their treatments done. So if we look at younger children, do they fare better than the young adults and the adolescents?
You know, Tapaswini, like for all cancers, we have what is called risk stratification.
Okay.
So whether it's leukemia, solid tumor, or a lymphoma, in all of them, we risk stratify. The purpose of risk stratification is, if this is low risk or favorable risk, let's give lighter treatment. And if this is high risk or unfavorable, let's give stronger treatment.
So any role of radiation for these patients? If we look at leukemias, is there any role of radiotherapy?
So radiation is a very effective treatment for cancers, generally speaking. For acute lymphoblastic leukemia, we have a part or component of treatment which is called cranial prophylaxis.
Okay.
So the CNS or central nervous system is a sanctuary site for leukemia. To prevent it, maybe 30-40 years ago, we used to do cranial radiation for everyone. But due to the late effects of cranial radiation, we now do only intrathecal. So in the leukemias, the role is somewhat limited. But for the pediatric solid tumors, for the brain tumors, radiation is a very, very effective treatment modality. In fact, I would like to say that cancer treatment in children is multidisciplinary, and there is a very important role of the radiation oncologist and the pediatric surgical oncologist in the treatment. And there is a certain time and sequence at which these treatments must be delivered so as to ensure optimum outcome. So it's not chemo alone, it's our radiation colleagues, our surgical colleagues, which have an important role. However, the pediatric oncologist would be coordinating all these activities. More so because chemotherapy is the backbone of most of the childhood cancers.
Correct. Right.
And the surgical and radiation treatments would be sort of local therapy strategies.
So in situations where there is relapse or the child fails, has a recurrence, where does the role of bone marrow transplant or the stem cell transplant come in?
Stem cell transplant, as you know, we call it hematopoietic stem cell transplant.
Correct.
We used to call it BMT in the days. Now we know that from the marrow, we get the hematopoietic stem cells. Now, the BMT has a role for high-risk leukemias. It also has a role for multiply relapsed diseases, which are chemotherapy sensitive.
Okay.
The main thing is that the disease, whether it's a leukemia, it's a lymphoma, or it's a solid tumor like neuroblastoma, the disease has to be chemotherapy sensitive. So what we do is we give high-dose chemotherapy.
Right.
But because high-dose chemotherapy would cause severe myeloablation, so we try to give transplant and have the donor cells which can rescue the child.
Okay.
If the disease is in the bone marrow, we ablate the marrow and then try to get healthy marrow, because the disease should not come back over there. So there is an allogenic transplant and there is an autologous transplant. The allogenic is where you have a donor who is someone other than the patient, who is HLA matched, and where the disease is in the bone marrow. While the autologous transplant is for a solid tumor, where the marrow is actually healthy. You take the child's own marrow, cryopreserve it, give high chemo, and then give back their own stem cells to rescue the marrow suppression. So there are two types. It's a very successful treatment today. Many centers in India are doing transplant in children, and importantly, the success rates are very good now, because the treatment strategies have become very fine-tuned and very advanced, and even here in India today.
That's really very, very nice and a good news to hear. Now, you've been into this treatment of children for so many years. It'll be lovely if you can share some inspiring stories, some touching, heart-touching survival story.
As a pediatric oncologist, our job doesn't end with the end of treatment. I will say that now for the cancer survivor, particularly if this is a child, we must follow with them. So for a couple of years to make sure they don't relapse, but subsequently to ensure that they are having productive lives. We ensure education. We try to counsel them because many of them have fears. Many of them are depressed. They are not sure about themselves. So in that way, what we have done is we have formed an after completion of therapy clinic, which we hold once or twice a week here. And we also now have a survivors group. It's a group by the survivors for the childhood cancer patients. It's called Ashai. So we have about 100 children who are now in the group. Basically, they have a newsletter to motivate each other, because there are issues with marriage, there are issues with jobs. There are people who don't give jobs if they know your history. There are people who don't give you insurance. So these are issues for them. There are stories, which would be stemming from children coming from the remote villages. Now we have a little guest house here, which is by one of our parents. It's called Grace, where they keep them free for 6 months. Because for 6 months, they have an intensive treatment. They can't go home. They don't have a place to live. So they have got very clean lodgings for them. We discussed earlier, the treatment is expensive. So we also have many NGOs with us. Rajiv Gandhi also now has a philanthropy department which tries to help children it's a curable cancer. It's worth putting the effort and getting the donation. So I will say that almost half of our children, they are on some financial support. And of course, everybody gets emotional support and everybody gets psychological and nutrition support.
Wonderful.
There are many stories.
Before we conclude, let's clarify certain myths with respect to these cancers. One, survivors have short lives. Is it true?
So when we say 5-year survival is 80%,
yeah,
it doesn't mean that they will only survive for 5 years. It means that if they have survived 5 years, risk of relapse is negligible and they will be long-term survivors. So they should live another 50 years.
The second is survivors are disease carriers and pose health risks to others. How correct is this statement?
Absolutely not. This is a total myth. Cancer per se, as we know, is not infectious. It doesn't spread from one to the other, and it doesn't run in families. So if a child has survived cancer and he is cured or she is cured, then it does not mean that their children have a higher risk of cancer. It's no such thing. It does not actually transmit to their children. So it is absolutely a myth.
Right.
They are not carriers. Cancer is not a hereditary disease.
Third is all survivors are genetically inferior and have fertility issues.
Absolutely no. They are not genetically inferior. However, certain treatments would have an impact on fertility. So certain alkylating agents, they do have an impact. The current treatment strategies, they try to reduce the cumulative dose of these drugs so that spermatogenesis is not affected. And in some of the older adolescents, we would actually do sperm preservation as well. But if you look at broadly, or if we say that cancer survivors are infertile, that would be totally untrue. They can have, I have many survivors who are married and who have normal, healthy children.
The fourth is childhood cancer survivors can never have a normal life.
That is untrue. That is untrue. But there is a big social stigma in the society.
Right.
And so because of that, so there is need for advocacy. There is a need to spread the word that this is not genetic. They are as good as the next person.
And the other is survivors do poorly in school and have some issues in future job placements.
Yes. So usually survivors don't have issues with schooling and they are good at their jobs. However, there is a social stigma and certain people try to not give them, they have these prejudices against survivors or with the word cancer is scary to most people. There's a big need in our society to sort of encourage these children who have had such a tough life and to give them opportunities which they deserve as per their capabilities. We should not judge them by their past medical history.
Right. I had read this beautiful thought which had been spelled out by a child's parent, and it reads as, diagnosed with leukemia at the age of 3. She said she learned to love the trees because in the winter their leaves all fell, but in the spring they grew back just as well. So when asked by others what she wanted to be, she simply said, I will be a tree. So you can appreciate this child's innocence and the burning desire to live. It's quite apt if we say the real superheroes live in the hearts of these small children learning to fight this big battle. Thank you so much, Dr. Gauri. Thank you so much. And this beautiful smile of yours and that magical touch of your hands, may it continue to bring happiness and joys in the lives of many, many, many more children that you're going to treat. And thank you, all the listeners. See you next week with another expert on a different cancer. Till then, goodbye.